Hi, we're going to move on to the next session. I'm Sandy Springer, and so all of those questions you have about intersection of research and policy, we can have another discussion. So I'm going to introduce our panel. We have Dr. William Powderly here, who's a former president of the Infectious Disease Society of America. He's currently the professor of medicine at the Washington University in St. Louis, and he's also the director of the Institute for Public Health there, and also the co-director of the Division of Infectious Disease. So we'll welcome him to come up to the panel. We'll start here. Thank you. And then we also have Dr. Elizabeth Hautzmuller. Is that correct? And thank you for coming. I know you just arrived. She's the Associate Director in Healthcare Delivery and Disparities Research at Patient-Centered Outcomes Research Institute, otherwise known as PCORI, for all of us and she serves as the chair of an IRB for a small research group in Baltimore. And we have Dr. Anika Alvanzo she's Assistant Professor of Medicine at Johns Hopkins University School of Medicine. And she has clinical expertise, including specifically in addiction medicine and internal medicine, and she serves as the medical director of the Substance Use Disorder Consultation Services there. And she's also the regional director and board member of the American Society of Addiction Medicine, or ASAM. So it's nice to have IDSA and ASAM representatives together. So what I thought we would do is, if you have your slide presentations, or if there's specific, you can come up to the podium and speak. If you don't have slides, then feel free to do podium or here, and then we'll have a discussion afterwards.
Thank you very much, and thanks for the opportunity to be here. Just to orientate you, some of you might know this, but Infectious Disease Society of America currently represents about 11,000 plus, mainly physicians, but other health professionals as well who specialize in infectious diseases, largely focused on issues related to patient care, education, research, and public health. And in about 19 years ago, we created the HIV Medicine Association as part of IDSA to really have a strong voice for the diversity of HIV healthcare providers and advocate for policies that would deal with this epidemic, the epidemic of HIV. In terms of activities that are relevant to what we're here today to talk about, we have partnered for the last number of years with the American Association for Study of the Liver Disease to maintain very current HCV guidelines. So these are updated on an ongoing basis, not needing the major 10 years to develop a guideline that then is no longer relevant. We have published guidelines on chronic pain management for HIV patients. We advocate quite a bit, particularly around HIV and ID prevention, care, treatment, and research. And we strongly advocate for evidence-based prevention, including syringe service and safe consumption. And that has been a policy endorsement for the last year for IDSA. And part of our education endeavors, for the last couple of years at our annual meeting, we've had major interest around opioid-related infections, because it's very clear from our members who work right across the country that this has become a major issue. And as part of that, we actually conducted a relatively informal survey of our membership to ask what were the major issues that they saw, and that it's no surprise infection and infectious diseases As a consequence of injection drug use, people are seeing many more cases. Infective endocarditis has become a major issue right across the country, but also you have issues related to skin infection, bone infection, and then you have the transmissible viral infections, acute hepatitis C and HIV infection. And we also asked our members, again, not in a formal way, what are the priorities? What are the things that they see as critically important? And you will notice that the responses to these aren't more antibiotics and there are more antivirals. They're around practice-related issues. The need to focus on prevention, and prevention related not to the infection per se, but prevention related to the cause of that infection. Syringe exchange, safe injection areas, education and safe injection practices, and then much more integration, increased access to medication for addiction treatment, and integration of this into primary care and into specialty care where appropriate, and in particular, and we'll come back to it, the need to have more supportive inpatient facilities to treat people who have acute infection, but to treat that in the context of also managing their addiction. To isolate these or to look at them as isolated problems is not going to address the issue. So we created a working group on, in fact, the intersection between infectious diseases and opioid use to really develop our policy as a professional society around this, and this working group has been working very diligently over the last few months. And the policy.
No, thank you.
The policy will be reviewed, and I anticipate endorsed.
No, thank you.
Okay.
Leo, could you mute yourself, please? Sorry. Leo is still
Sorry. The policy will be reviewed, and I anticipate endorsed at our board meeting on Friday and become the official position of IDSA. But it really focuses around a number of areas, and I'll touch on each of them. The issues around prevention, about needing more data, about developing capacity to deal with this crisis, both at the terms of provider but also in terms of access. And finally, but no less important, issues related to research. So in terms of prevention, we need to invest in new resources in the CDC and in the entire public health sector to build capacity to respond to the epidemic. We obviously need, and we've talked about this, the expand access to syringe services, exchange. We need safe consumption sites and support jurisdictions that wish to do that and to advocate for that this is an evidence-based. And we need to fully implement our national guidelines. One of the things that we heard around the legal issue this morning is the fact that there is this disconnect between developing guidelines, developing laws, developing policies, and then actually implementing them. And that we don't. From a public health perspective, it's not that you don't need new technology. New technology is always nice. It's wonderful. People like to play with it. But if we just implemented the technology we had, we'd actually make a great difference. We need better surveillance. We need, particularly around the infectious disease part of the epidemic. We need expanded surveillance for hepatitis C to really see what's happening with acute hepatitis C across the country and identify what the role of opioid use in that, driving that epidemic. We would like to see more epidemiological data on the mortality and morbidity associated with the infectious disease complications, particularly bacterial endocarditis. But I want to just caution here that just saying something like this in the absence of funds is yet another unfunded mandate for already stretched state and local health departments. And So to put something like this into a policy and say this is what we should do and then not put any resources behind it is really only going to get you bad data because you'll either get it poorly done or it won't be done at all, and it just will not add to our capabilities. So it is very important to have this as an aspirational policy, but to turn around and say that yet another unfunded mandate is really just going to cause more problems. And we've seen that many, many times, and we don't need to keep saying it. We do need to build healthcare provider capacity, and this is particularly true around the complicated issue of infectious diseases. Well over half the hospitals in the United States do not have an infectious disease specialist. That when you confine that analysis to rural hospitals where obviously there's a significant part of this epidemic, it's actually closer to 70%. And so we need to have access to that service and potentially leveraging telehealth or other technologies. And if you think infectious disease services or access to infectious disease services are poor, access to addiction services are even worse. So that is an important issue. Better training on addiction for clinicians, including infectious disease specialists who are involved in this, who want and need it, would be an important policy initiative. But we also need to be able to, we have to remember that many of these people are already very busy. They're already working very hard. And so even if they have the training, we need to provide them with the support services and the access to counselors, the access to case managers. And we also need to try and get physicians in the places that they're needed. And one of the ways that really has worked and could continue to work is to target underserved areas by expanding loan forgiveness opportunities and therefore creating a market in order to get more physicians in places where they're needed. We will advocate for expanded access to addiction treatment and for treatment of HIV. So in addition to building the capacity on the physician side or on the provider side, you also need to have, you can't let them be in a situation where they've been trained to do this and now their patients can't actually get access to the therapies they need because of other barriers. We've heard some of the legal barriers, but just to expand on a couple of them, obviously we have insufficient access right across the country for medication for addiction treatment. But we also have, it is also really not integrated at all with the delivery of any other services. And that lack of integration, I will contrast that to countries that actually have functional healthcare systems, where you actually can have addiction specialists and infectious disease specialists round together on patients with active infections and have a treatment plan that's integrated, and the patients are actually referred immediately to methadone or other, and they receive the remainder of their infectious disease treatment in methadone clinics. It's not rocket science. No new technologies. Doesn't require precision medicine investment. Just requires us to be sensible. We have opportunities within existing programs around HIV that are actually can work, and they're well-resourced in terms of case managers, in terms of other opportunities, but obviously we need to be able to have access within the Ryan White programs to prevention and treatment for HIV-infected individuals who have substance use problems. And I would remind you, sometimes overlooked, that the rate of substance use, both alcohol and drug, in the HIV population is greater significantly than in the general population for many reasons. And therefore, leveraging what we have already in place that works would be relatively straightforward. And we need to decrease barriers to HCV treatment. Many states or jurisdictions require have put on limits that make no medical sense whatsoever, and particularly when you're down to an issue of 8 to 12 weeks of treatment to cure an infection that is potentially transmissible to other individuals, as well as obviously causing illness in the individual who has it. To put barriers against that treatment that are largely driven to the basis of hoping that the provider won't, or the payer won't have to pay for it, is problematic. Integration we've talked about, but I think we talked about the need for integration between inpatient and outpatient. But we also, and we heard it as a question in the last session, the integration across places, particularly the vulnerability and vulnerable population of patients who are interacting with the criminal justice system, and improving that integration and linkages is important. And then obviously, and I'm sure we'll have more discussion of it, the integration across specialties so that we can have better care there. And then there are research issues. They come to some of the implementation science questions of if we set up a model, can we develop models for co-treating and integration addiction and infectious diseases? What models work? What models are more cost-effective? What are the outcomes of interest that we want to actually determine, and then figure out how these work? Very practical issue in the treatment of endocarditis, which is often staphylococcal, is that we have drugs, long-acting glycopeptides, that have not been approved by the FDA for anything other than skin and soft tissue infections. There's a tremendous interest in how they could be used for the treatment of endocarditis that would actually allow people to get out of hospital, but you then have to make sure that they actually work. And you also have to then have an integrated approach as who's going to administer them, how they're going to be administered, and effectively. And the ideal situation would be obviously if they could be administered in the context of also offering addiction treatment. That would really make sense. And then effectively implementing other interventions and having it properly integrated, and going back to this issue about having an intervention implementation science approach and appropriately funding that. And I think one of the things we've seen this map in the last presentation, but it reminds us that that we have vulnerable populations, justice-involved individuals. We've heard about that, and rural populations. And we currently have, because these are not necessarily regarded as populations that are in the traditional minorities populations. They don't have the same access to some of the funding opportunities that are out there, and yet these parts of the country have been particularly vulnerable to spread of HIV and hepatitis C, and recognizing that we have very significant poverty-related issues, not just in our urban core, but also in our rural populations, and addressing those and is a very important issue in terms of prioritizing our research endeavors. So, just to summarize, as a physicians' society, we are very committed to this whole issue around evidence-based policy, education and advocacy. So it's not just education of our members, but advocating on their behalf at a state and federal level. We will be publishing very shortly a fact sheet for our members. We'll also, as I said on Friday, I anticipate that the board will approve the policy brief and recommendations and then disseminate that. And we've been asked by Tony Fauci to provide advice to the NIH, to NIAID, on what are the key research issues related to infectious disease and the opioid epidemic, and he specifically invited that from us, and we will be obviously very pleased to respond as to what we think are the priorities. And taking all of that, we will outreach to Congress and the administration. I look forward to a day on the Hill on Thursday. We'll advocate for these policies and really emphasize the need to have integrated thinking and address the intersection of this epidemic with infectious diseases. And I think one of the things is that having the infectious disease community really be part of this advocacy is important because we recognize what epidemics are. The language of epidemics is the language of infectious diseases. And I think that will be an important issue. And obviously we will socialize this as much as possible. So thank you for your attention, and we'll take questions later, I assume.